Community urology is a branch of our specialty that is becoming ever more increasingly in demand. On behalf of the Department of Urology at Ashford and St Peter's Hospitals NHS Trust, we would like to propose a new community urology-based service for which we seek support. We are suggesting the development of a unified primary and secondary care catheter service that will be hosted from the Urology Village in St Peter's Hospital. There are many drivers for the inception of such a service. For example, in 2014, the NHS England and Department of Health published a 5-year forward view. This championed a redesign of services that are to be integrated and responsive to patient needs. Likewise, the Catheter report into the future direction of our ambulance services remarked that a new focus would be to resolve problems at source rather than transfer to hospital. More recently, the NHS 10-year plan has been taking shape. Some of the key remarks are of direct relevance to this project proposal. First, we need to be putting the right things in place for NHS services to improve. This project does just that. Second, we are challenged to think of the sort of staff that we are going to need. This project does just that. And third, we're asked to suggest what will help people live healthier, independent lives in the community. Again, this project champions this ideal to the core. So what is the problem? Let us just take a few moments to scale the impact of human urinary catheterization on clinical life, both in the hospital and in the community. First of all, it is estimated that there are about 120,000 catheterized patients every day in the United Kingdom. At any one time, there will be 28,000 catheterized patients in NHS hospital beds. That is 1 in 5 of all hospitalized patients, or about 20% of those who are currently in a hospital bed. The numbers outside hospital are even greater. It is estimated that there are about 90,000 catheterized patients in care homes or in their own homes within the community. That means that about 75% of all catheters that are in use are for individuals dwelling in the community. For most of those, they are likely to be long-term devices. However, if we just consider the 1 in 5 or 20% of hospitalized patients who have a catheter, we know that about 31% of those have actually been admitted to the hospital with a catheter already in place. Of those, 40% have a catheter-associated problem, and 60% a non-catheter-related problem. Of course, some will have both. However, what do we mean by catheter-associated problems? What are the catheter-associated problems? Well, there are very many. For example, we may get catheter blockages, bypassing. Bladder spasm and pain can be a problem. There is nothing nice about having a catheter. Hematuria, or blood appearing in the urine, is a common consequence of having a foreign body rubbing on the inside of the bladder, and it causes alarm. Failure to actually pass a catheter is not uncommon, especially in males. Indeed, a failure rate of about 4% is generally noted. Such failures can result in many further fruitless attempts, and untold damage can be caused. Urethral trauma is a common sequelae to inexperienced practice. Indeed, urethral strictures, that are just healing scar tissue, are nearly always a consequence of previous traumatic catheterizations. Trauma can occur on the outside of the penis too. Penile cleavage occurs when a catheter cheese wires through the penile tissues. This is usually the consequence of a long-term catheter in a frail and immobile patient. A paraphimosis is a swelling of the pulled-back foreskin. This occurs when an inexperienced operator forgets to replace the foreskin after passing a catheter. However, perhaps the most egregious of catheter-associated problems is having a catheter that is not actually necessary. Patients are often catheterized and then their care is transferred to a different team. Some estimates have suggested that, at any one time in hospital, 15% of catheters are not necessary. Then there is the vexed problem of catheter-associated urinary tract infection. Difficult to define, often overdiagnosed and frequently badly managed. Coupled with this is an entrenched problem of poor antibiotic stewardship. Let us just consider this couplet for a moment. Recall that 31% of all catheterized hospital patients have been admitted from the community with a catheter already in situ. Of those, 1/3 have an infection-related problem, and a small proportion of those will go on to develop a full-blown gram-negative septicemia. In 2017, the Department of Health, through Public Health England, made gram-negative septicemia a notifiable healthcare-associated infection that is now being monitored by the CQC. Of all gram-negative septicemias, 30% are catheter-associated. Of those patients who do badly, poor antibiotic stewardship is often implicated. All catheterized bladders become colonized with bacteria, and inappropriate antibiotic therapy will clone out antibiotic resistance for all those who are exposed to injudicious antibiotics. Indeed, in 2017, the World Health Organization issued a global warning alerting us all to the catastrophe of antibiotic resistance. And this is teeming away quietly, somewhere in a bladder very close to your home. The misuse of antibiotics in long-term catheterized patients just cannot be ignored and requires address. Or put more simply, specialist oversight of catheterized patients in the community is a central proposal of this project. Okay, so there are a myriad of catheter-associated problems going on all over the place. But what sort of things compound the problem? Well, in the community at least, the problems are often magnified by the fact that so many catheters are placed as a long-term solution for continence issues, and problems are compounded by fragmentation of services. In recent years, we have seen a plethora of publications and reports highlighting this woeful fragmentation of the services that support catheterized patients. There are many reasons for this, but in the main, the problems usually centre on the boundaries for responsibility. For example, who is responsible for a community-based patient with a long-term catheter? Is it the general practitioner? Or the community nursing team? Is it the responsibility of hospital-based urology nurse specialists? Or hospital-based consultants? Whatever, a clear problem is the blurring of boundaries. Let us just consider a patient who has had a catheter for more than 2 years. One study has looked at the need for professional intervention or help over a 1-year period. 75% of patients have called for help at least once in that time frame. Actually, the average number of call-outs is 4. However, a small proportion, perhaps 6%, have made up to 10 call-outs in a 1-year period. These are often referred to as frequent flyers and are a special challenge for the ambulance service. But what do we mean by professional intervention or help? What services actually exist? What options do patients actually have? Well, in the main, there are 3 main services available. The first is the community nurse. The district nursing service responds to patients who are having problems at home. The second may be a dedicated catheter clinic that usually operates out of the main hospital facility. And the third is the accident and emergency department of a secondary care hospital. Let us first consider the community nurse. Some studies have suggested that catheter problems comprise about 5% of the overall workload of a community nurse. Many such nurses are able to perform changes of urethral and suprapubic catheters and are happy to perform bladder washouts and precipitate specialist referral where appropriate. However, there are clearly limits to what such personnel can achieve in the home, and not all are prepared to undertake these most basic interventions. Indeed, not all catheter changes are straightforward, and doing such procedures in an unsupported environment may not be the best solution for all parties. Furthermore, an independent report from the King's Fund has suggested that between the years of 2000 to 2014, there has been a 54% reduction in district nursing posts. Clearly, this has been one service domain where there has been an insidious stretch on resources. The availability of dedicated catheter clinics is highly variable. In our organisation, the Urology Village at St Peter's Hospital will see between 4 to 14 patients directly each week. These patients will have called directly or will walk into the department. Where dedicated catheter clinics have been specifically set up, there are published reports of success. For example, this publication from Bristol showed that following the inception of such a service, catheter-related attendances in the A&E department were reduced by 73%. Now, we need to consider the role that the A&E department plays in managing catheter-associated problems. Often, this is the crucible, or the melting pot, where all manner of desperate healthcare problems coalesce. In the summer of 2018, we conducted an in-depth audit of how catheter-related problems were dealt with in the emergency department of our hospital. On average, there were about 2,000 attendances per week. Each week, about 30 catheter problems were identified. 2/3 of attendees were having problems with a long-term catheter. 1/3 were awaiting a trial without catheter, and for 11% the reason for the catheter was either unclear or unknown. 41% of patients had self-referred. 45% were referred by carers or care home employees. 14% had been referred from community nursing teams. This data is relevant when we consider the impact that our new service might have. For the greater majority of patients in this group, the community catheter service would presumably have offset most of these attendances. When we consider the reasons for attendance to A&E, we meet the usual suspects. Notably, 1/3 had an infection-related problem. Blockage and/or urinary bypassing, catheter-associated hematuria, and bladder spasm were the most common problems. 1/5 had a concomitant problem that also required address. However, despite the fact that many of these, especially catheter blockages, are relatively simple problems with straightforward solutions, 70% of patients were still admitted. Furthermore, once admitted, the mean hospital stay was 7 days. This data deserves focus because when we compare loco-regional data, as was provided by the South London HIM Patient Safety Collaborative, we see that other hospitals in our region have a much lower admission rate with a shorter subsequent mean stay. It is also worthy to remark that of those discharged from A&E, 40% left out of hours. Furthermore, of those arriving in A&E, 75% were brought in by ambulance. Let us shift now to the impact that catheter-related problems have on the ambulance service. Using CCAM data, we know that there are 5,000 catheter-related calls per year. That is 1.5% of all call-outs. 90% of such calls result in a conveyance to hospital. The estimated cost for each conveyance is about £650 or £130,000 per year. But of greater significance is that many ambulance crews are then tied up with many relatively trivial problems that could be resolved on site. Of course, this was a key theme of the Carter report, which challenges the ambulance service to resolve more problems at source. So let us now look at the more global organisational impact that catheter problems have for St Peter's Hospital. The Trust has a catchment population of 410,000. We estimate there to be about 610 catheterised people living in the community served by this Trust. With regard to the Trust itself, there are 361 beds with about 80 catheterised patients at any one time. That is 22% of all inpatients. In addition, our own audit has described about 60 catheter-related events per day. Such events might include catheter placements, changes, unblockings or removals. But who has oversight? Who is taking overall responsibility for this heterogeneous and widely flung group of generally vulnerable individuals? With 80 hospital inpatients and 610 community-based patients, this is a challenge. During the Second World War, Britain was under constant yet unpredictable attack from the skies. But the air raid activity was under constant radar surveillance in control room bunkers deep within the home counties. When rapid responses were required, the Spitfires were sent in. We suggest a similar control room deep within the urology village. A dynamic database is kept while we will have a constant surveillance of our community map. We will know where all of our catheterised patients are at any time. Those with ongoing problems will be flagged for response, and all patients, their carers, primary care physicians and community nursing teams will have direct access to the control room. Similarly, all catheterised patients in the hospital will be under the same monitoring process and problems flagged for redress. The urology centre would be a hub and spoke model serving both primary and secondary care. From hospital wards to the patient's home and even into the community care homes, the catheter team would have complete oversight. This team will comprise 6 specialist nurses who will work in all domains. Put simply, they would have responsibility for the 80 hospital inpatients and the 600 or so community-based patients. 4 consultant urologists will be job planned with 1 PA each. They would then be the consultant team who would have definitive arbitration on all catheter-related matters. They would have ready access to diagnostic endoscopy and, by using their own operating lists, they would deal with all the bladder washouts, diagnostics, Botoxing and suprapubic catheter insertions as might be appropriate. There will be a specialist clinic timetabled every week to ensure that both patients and the specialist nursing team would have direct access for prompt review and, of course, the nursing team would have access to the consultant team at all times. One member of the nursing team will be on a higher band and serve as the team leader and the programme and procurement lead. He or she will work closely with the finance and procurement personnel. This working relationship will have special relevance to purchasing in the community. At present, there are at least 13 different suppliers of catheters and catheter-related products across our patch. This catheter budget is estimated to be about a £1.8 million spend a year. By centralising procurement, we will be able to make savings from the centralisation of purchase. The product purchases will be more logical. There will be less redundancy and wastage of products. There will be better tailoring of products to patients' needs. And finally, there will be a better standardisation of practice. But standardisation of practice takes on many other guises too. And here, the catheter team is central. The National Catheter Education Programme has been developed by the urology team at St Peter's Hospital, and the catheter team would all be faculty members. This project seeks to rationalise catheter care alongside sound clinical and scientific principles. It brings a universalisation of concepts and language to a new higher standard of care. It is a dynamic, ever-changing course that is responsive to feedback from patients and participants and has evolved to be a consensus product that is being spread out nationally. It is a multi-professional educational programme that is being delivered to doctors, medical students, midwives, nurses, community nurses, paramedics, carers and care home workers. The programme is called The Secret Life of Catheters and consists of a series of animated teaching themes that are punctuated with iterative questions and reinforcing case histories and discussions. It is delivered in both a face-to-face teaching environment and as an online version too. But of greater importance is the fact that it is the first teaching programme to be linked to a systems change agenda. The catheter team members, as faculty members of the educational programme, are able to truly extend the teaching back into the workplace. The systems change agenda is clear. The goal is to use the educational tool to drive improvements in care standards. But defining improvements in care standards can be tricky, but we have done just that. With a heavy emphasis on delivering the course to our own hospital staff, the community and paramedic teams, we have been able to show that there have been many improvements to clinical care. We have seen improved documentation. There has been a reduction in unnecessary catheterisation. There have been fewer catheter-associated injuries. We have seen reduced transfers from care homes. There has been a reduction in conveyance by ambulance to the A&E department. We have seen reduced admission through A&E. And finally, there has been better antibiotic stewardship evidenced. The National Catheter Education Programme and the new catheter service proposed here are separate entities. However, by linking them, we anticipate that the sum will be greater than the parts. The purpose of this presentation is to raise all of these exciting possibilities for discussion. So, in summary, a unified primary and secondary care catheter service fits many of the demands of the NHS 10-year plan. Indeed, it could be the poster child for these NHS aspirations. Let us articulate some of the key benefits. There will be a universalisation of care standards. For many community-based patients, there will be immediate home access to specialist care. The right patient gets the right place at the right time. There will be a more seamless patient experience. There will be a reduced load on the ambulance service and accident and emergency departments. Many hospital admissions will be avoided. This service should be a welcome support for our community nurses and primary care physicians. And finally, there will be vast cost savings and a rationalisation of procurement of catheters and catheter-related products.